All right, please, ladies and gentlemen, permit us to effect some changes. We sincerely appeal to the plenaries that are supposed to be coming up before Dr. Salma's own. Please, she has to go somewhere, so we'll please take that on high impact practices, scaling up what works to achieve Nigeria's family planning goals. I will want to invite straight to the high table Dr. Salma Anas Ibrahim, Senior Special Advisor to the President on Health. A round of applause for her as she comes up. And we also have Ms. Ogechi Onoha, Director Operations, Maristopes Nigeria Reproductive Choices. A round of applause for them. We can do better. Please, let's appreciate them as they come. Dr. Salma, please, 25 minutes. Thank you, ma.
It's a panelist, isn't it? Yes, it's. Are they all here? Hopefully.
You have the list.
Maybe I can call the panel out. Yeah, please call them out. But you will introduce us. And I'll introduce the panelists. Because I'm prepared to do that briefly. Please be on their name so that. Okay. You want to call them out? You call them out? Yes, all right, go ahead. All right. Sorry, let's sit. Let me go to the middle.
Sorry.
Good evening. We want to welcome you to this session on high impact practices sponsored by the FP 2030. I'll very quickly call out the panelists for the session. We have on the panel Dr. Emeka Nwachukwu. Dr. Emeka Nwachukwu is a seasoned epidemiologist. He currently works with USAID and has many years of experience. Dr. Salma needs no introduction. She's the chair for the session, and we all know her. So I'll very quickly move on to the next member of the panel. We also have Dr. Kasa Abe. Dr. Kasa Abe works with the children. Please take a seat. Dr. Kasa Abe works with the Children Investment Fund Foundation, and he is the Director, Health System. Dr. Kasa, please, you're welcome. Also on the panel, we have Dr. Olusegun Samuel Oyeniyi. Dr. Olusegun is the Director, Reproductive Health at the Federal Ministry of Health and Social Welfare. Dr. Samuel Oyeniyi. So while Dr. Samuel takes his seat, I have the pleasure to also invite Dr. Sada Damusa. Dr. Sada Damusa is the CEO, Development Outcomes. Dr. Sada. And lastly, we have Helen Anyasi. Dr. Anyasi is a doctor with global health experience, and she currently works with the BMGF. Dr. Helen Anyasi, please come up and take your seat. Yes, I have. Oh, my apologies. All right. So we have our seasoned panelists. I will pass on to Dr. Salma to kickstart the conversation. Yeah, but before Dr. Salma starts the questions, we will have Dr. Emeka Nwachukwu just share a few slides to get the conversation started. Dr. Emeka?
Thank you, and thank you, everybody. I have a slide deck that should be projected. I don't know if that is going to happen. Okay. If that wouldn't happen, I can run through this briefly because of the time we have, and thank you all for joining this session. This panel is about the high impact practices for family planning, which the USAID had started and been working on the past 12 years. Secretariat had moved to FP 2030 just early this year, and we're happy to be talking about it. It's a tool to help achieve your FP goals, whether at the country level or program level, or, even at the health facilities, whatever you want to achieve. We know that there are many different ways to increase knowledge and access to family planning, but decision makers do not have all the time to review the evidence across all potential interventions and to use. At the same time, there's lack of consensus on what works, what does not work, and how to use them. So to bring a solution to this problem, we started this evidence-based family planning practices process, which vets evidence, curates them against specific criteria, and documented in an easy-to-use format. The HIPS is a global partnership made up of different small components. The first of them are called HIPS co-sponsors. The co-sponsors are responsible for coordinating the partnership. They are USAID, UNFPA, WHO, IPPF, FP 2030, Gates Foundation, CIAF, and most recently, the Packard Foundation. There's also the Technical Advisory Group, which is more like a board, includes 25 experts, researchers, implementers, and policymakers from both low and middle income countries, who provides overall technical direction. Okay. I'm on the next one now. They provide the overall technical direction to the HIPS. Then there's a stakeholder engagement group, which is hosted by WHO IBP networks, responsible for disseminations, webinars, external communications, monitoring of HIPS implementation and its usage. Like I said earlier, the Secretariat has just moved to FP 2030. Next slide. What comes out of the HIPS partnership and activities, we call them products. They are not programs. They are not things to plan for or implement in themselves. They are products that will help us to channel our investment to what was most in what we are already implementing so that we can have more result and better impact. The products are set up in three formats. There are HIPS briefs, there are HIPS enhancements, and there are HIPS strategic planning guides. I can leave this a little bit for you to read through and see what they are. The HIPS briefs have a development process which is complex. You can't go through that now. But this starts with a concept note, and anybody can write a concept note on what you think should be included as a high impact practice. The concept note goes to the TAG, and the TAG discusses it. If they approve it, we'll form a technical expert group that sits and starts producing whichever type of product we want. Right now, a TAG is sitting to produce a HIPS brief on self-care in family planning, because concept notes came through, was approved, and the development process have started. After the TAG, the brief goes public through public commenting and review process, comes back to the TAG, they review it, then it goes back to the TAG for final approval before it goes to the HIPS website. This is all the processes it goes through. We'll leave it at that. The HIPS are pretty much used, next slide, for program design, prioritization of interventions to implement and scale up, and for advocacy, and for any other thing you think is useful to do, use it to do. Some HIPS can be applicable across programs even beyond family planning. For instance, there's a service delivery HIP on mobile outreach. So this is not just mobile outreach for family planning, it can be applied across other areas. That's the website, www.fphigh'impactpractices.org. Please, it would be nice to go through it and see a whole lot more than I can talk about today. Next slide. That website contains different kinds of resources that will be useful when you are trying to use any of the products. There are implementation tools. These are just examples of the few briefs that are there. There are information on webinars from IBP Network, checklists for implementation readiness. There's a metrics developed by the WHO on how to implement this. And currently we are developing a HIPS measurement toolkit that will contain a measurement framework, sample protocols, tools, and other things you need if you want to measure the extent, reach, and quality of the HIPS that you are implementing. What HIPS have been prioritized in Nigeria? The HIPS have been implemented locally here in the country, and we've had organizations implement mobile outreach, FP in humanitarian settings, and you can read the rest of them. But all of these are included in our current FP 2030's commitment as what the country wants to do. Last year, Bill and Melinda Gates Foundation funded Track 20 to conduct one of their models called FP Goals. And this FP Goals, next slide, identify 3 strategic priority intervention areas that can be used, applied to the HIPS to gain more impact. Those are to increase accessibility to contraceptive methods in the public sector, use of postpartum family planning, increase demand generation activities, eliminate all stock out of contraceptives. See how slow that is. I hope it's possible. WHO is also conducting a bottleneck analysis to help us see where the problems, issues are, and how to start solving them. Okay, sorry if I rushed this through, it's because we're also being rushed. It's my pleasure to have introduced the panel and hand over to the chair of the panel, Dr. Salmas Anas Ibrahim, to take this on. Thank you.
Thank you so much, Dr. Emeka, and good afternoon, everyone. We've been asked not to do any protocol because of time limits. We have only about now, maybe 17 minutes to do. So she has already done an eloquent, a very brief introduction of all our panelists. So you are all welcome, and everybody has heard the background of about the high impact projects from Dr. Emeka. So let us have a live experience. They have their hands on the job. So let's hear from them how it is. So I will start with you, Kasa. I've been looking forward to see you because I've read a lot about the work you have done, especially in Ethiopia and Malawi. Exactly, and Malawi. And I think they are doing great. They are making a lot of progress in these 2 states. So looking at HIPS now, can you tell us how HIPS may be integrated into the SWAP? SWAP, the sector-wide approach, which Nigeria is currently trying to roll out as a process we have adopted, to traject our realization of our aspirations, especially within improvement of maternal health and family planning uptake. So let's have your experiences, how it has worked, and how we can do it better. Thank you.
Yep, thank you so much. My name is Kasa. I am a Health Systems Director at SIV. I had a chance to work in a couple of SWAP situations. And I just wanted to start by saying congratulations for bringing back strongly SWAP in the African landscape. SWAP works. It's a very strong instrument, probably one of the best instruments for sustainability, for bringing confidence across development partners and increasing domestic financing and getting more and more confidence from Ministry of Finance or other government bodies. So I just wanted to start by saying, I think Nigeria is probably the best country, probably the only top 2-3 countries in Africa to use the SWAP to change the story on family planning, on women's health, maternal mortality. So you're in a special moment in history, and SWAPs, from experience, they go up and down. So now is the moment. It's a lot of excitement, opportunity, and it's the time to start cashing in some of the interventions like family planning and HIPS. So just a few examples. As much as swap is really nice, it takes a lot of process, a lot of joint agreement, consensus, mutual accountability, and we need to use that process properly to start using it as a financing and a coordination mechanism. So, for example, in terms of HIPS, HIPS is a done deal. We know they have really nice best buys. So you don't need to make a case on HIPS, on family planning, because the case is out there, the evidence is out there. So the nature of swap is, you'll see it, when you start swap, all programs, all initiatives will come into the table. So the competition will be, show me the evidence. And this is really one of the most known best buy, which makes consensus in the room easy. So I would use that opportunity to make a strong case to put swap in your working groups, in the swap steer committee, to convince and keep it there. So that there will be a lot of competition from eye health, from mental health, from hospitals. So it needs a champion. I don't know who will be that champion for family planning, for HIPS, to keep pushing across the states and in the federal. Maybe it can be your team, Dr. Samuel, but it just needs a champion to put eyes that this is kept in the plan and then has made it through the bigger governance, the swap stairco, where the ministers and the directors of agencies sit together. So that's one tip. But the next one is, how do you put reporting, DLI, how do you link it to family planning? I would leave that to you, but that's one of the most important area to make it happen. Because if we don't report, swap will start getting questioned a lot. That's the mutual accountability. It's not only one side, it's two-side accountability. So we need to show some numbers and reporting. I think I'm running out of time. Let me give some 3 examples, quick examples, how countries like Ethiopia, maybe Malawi, Mozambique used it. And you would like it, Dr. Samuel. So one way is to start investing, let's say, on community health workers, or IPPF, postpartum family planning in your case, or post-abortion family planning. So that's a cross-cutting solution where delivery, pregnancy care can be done, and the community health workers can be doing a lot of things. The other piece is commodities and getting your facilities ready. So that's a primary healthcare investment, which can do delivery and maternal care. I think I would like to kind of stop by suggesting my last piece, which is you can pilot HIPS. You can pilot 3 things: postpartum family planning, community health workers, a package, let's say in northwest Nigeria or northeast Nigeria. You start from a low CPR areas and scale up. Thank you so much. Sorry for taking
Thank you so much. I know you have so much to say, but we will continue the discussion out of this meeting. So yes, I think you've raised, we can have a champion, somebody that leads on swap, in all aspects. So that takes us to Dr. Samuel Oyeni, who is currently the head of reproductive health within the Federal Ministry of Health, and he is in the midst of it. So let's hear from you, Dr. Samuel. Nigeria has been implementing the high impact project, which is anchored within the Federal Ministry of Health in your department, in fact, in your unit, for some time now. We've been implementing the HIPS. And then we have identified 2 aspects of that. In terms of family planning, we have prioritized the postpartum family planning and also the post-abortion family planning. So I would like you to share with us the scaling up of these 2. As a woman, I truly like the postpartum family planning because that's the best time to catch women, to listen to you. after the pains of labor. So let's hear from you. How do we scale up that? Dr. Eni, and how do we integrate these hips into the broader RAMCA? You know, when we say RAMCA here, hello, RAMCA is reproductive, maternal, newborn, child health, adolescent. We always miss that adolescent health, plus nutrition. So over to you.
Thank you very much, ma. The pain after labor sometimes is being forgotten too quick. And many women delivered, and you will be so surprised that they still come back after 6 months asking doctor, I missed my period. I have not seen it. I saw it once. And you'll be so surprised they can still be pregnant within that period. So they become high risk. That pregnancy become high risk pregnancy. And that's why postpartum is very, very key. In postpartum, you can have a normal labor, normal delivery. You are cancelled, and you can take contraception. But what of those that have maternal complications? Postpartum, PPH, like I said in the morning, preeclampsia, eclampsia. Some with unsafe abortion can also happen. The question is, will you just allow them to go without due counseling so that it will not lead to mortality at the end of the day? And that's why the direct impact of family planning on the reduction of maternal mortality is very, very key. That we look at the integration of FP into MNCH. Very important. And what have we done? We've been able to include postpartum family planning in terms of policy into our policy documents. The same model strategy that we developed to be able to guide the direction, both at subnational in terms of implementation and at national level. That we have been able to do. We also include it in the blueprint that every one of us were aware of. And we developed the guideline to integrate family planning into MNCH. And that is what we mean for the postpartum and post-abortion family planning. And we have gone further. There's something we call ending preventable maternal mortality. It's a global movement. And we developed an accelerated plan for it that we submitted to the local organizing committee of the EPMM. And we included postpartum family planning and post-abortion family planning activity in that acceleration plan. And that enables us to give reports each time to this global network. What of advocacy? In terms of advocacy, we all know that we have some challenges even at the subnational level. What are these that is not enabling us? And one of the major challenges, because of the independent nature, in terms of Earth being a concurrent list. And that was why we signed the compact, to be able for the state. And we presented some memo in the NCH, even the one we have just ended. So how can we go around it? It's through advocacy. So we develop an SOP that each time we go to the state, we've started with all the maternal health complications, postpartum. So all the partners at the state come together and we give that advocacy like a week, either to training or whatever implementation we have at the subnational level, to pay visit to the commissioner and discuss around reduction of maternal mortality. So not only government alone, all the stakeholders, WHO within that state. And that is what we have been able to do. And we've been able to, we visited some states already with the SOP attached to it. So that we'll be able to do. But at the state level, we don't have a fundamental department that we can say this will take care of maternal, newborn, and child health out of 37 states. Those of us that were in Maduguri, we still presented that memo. We need that department as basics to be able to have foot of charge, to be able to implement guidelines, policy from federal government that has to do with women, newborn, and children. If we don't have that at the states, how would they be able to have foot of charge or allocations for issues of RAMCA, issues of maternal health, and family planning inclusive? Out of 37 states, maybe 5 has created it. And the data is there for those that have created, for us to see how they have been able to improve. So that is also one of the advocacy we're also making, so that we can implement better, coordinate better, collaborate better, partner better at the subnational level, because that's where the implementation is. With the LGA autonomy in terms of finance and implementation, I think that will help us moving forward down to the grassroots to move our RAMCA implementation forward. What of capacity building? Every capacity building we have, if you are doing MNCH, you have to also finish it all with family planning. If you are doing family planning, you have to finish it all with postpartum and post-abortion. And some of the partners are here that are already doing that, moving down to the state. Because of time, quantification is one of what I want to talk about. Awareness creation and our celebrations. Health Day celebrations, same model celebrations, we're already at it. It's going to come up in April next year. And postpartum family planning, post-abortion in relation to MNCH will come up in a very unique way for us to be able to scale up this implementation. And for data, we're already disaggregating on NHMIS so that we can have data for those that have postpartum family planning and post-abortion family planning. Then we can use it and disaggregate by state and be able to know our performance and know the state we need to step up and where we need to put up more advocacy for their implementation.
Thank you
I
so
think let
much,
me stop
Dr.
here,
Eni. Thank you so much, Dr. Eni, for sharing with us how you've been able to integrate. So they are telling me to move very fast. I think what I didn't say at the beginning is that when you are speaking, looking at the audience, you should also look at me, because I control the time, so that when I say stop, you stop. So thank you so much. You've talked about data, and that takes us to evidence-based. You know, whatever we are doing, it has to be measured, it has to be evidence-based that it is working, and that is why they are all high-impact projects. So that takes us to Dr. Sadat Amusa. Dr. Sada is a public health expert and is well known for evidence. In fact, I call him Mr. Evidence, because he said we have evidence that it is working. So Dr. Sada, kindly share with us, you know, we're talking about scaling up HIPs in Nigeria. Based on evidence that you have seen in the past few years, what are the best practices in scaling we should consider?
Thank you very much, Dr. Salma. I think this is an interesting question because there are a lot of best practices, and I think we don't have time to go into all of them. I will try and concentrate on those ones that relate to the evidence and those that are unique to Nigeria.
And you have just 1 minute, 1.5.
That's not fair.
All right.
So I think when we hear HIPs, we do know that they are evidence-based, and the fact that they have already been tested, we just feel that this is something that we can just identify, grab, and run away with. But in reality, that is not the case. They need to be adapted to context, especially in a country like Nigeria, that the context is complex. The size, the population, and the 3 different levels of healthcare system with actors and government that are almost semi-autonomous. So it's really important that we understand what are those things that we can do better to make sure that we implement HIPs. I will give an example of what Kasa talked about PPFP. So the key issue is that you need to look at what are the channels that you can get to the grassroots, right? One unique thing about the Nigerian healthcare system is that there is a big ditch between the formal healthcare system and an existing community healthcare system. The formal healthcare system ends at the primary health care, and then there is down there a community health system that they are, doing their things. Over 60% of them look for the next PPMV to enter, right? And, except recently we don't even recognize the PPMVs. Yet we have some people at PSC that are supposed to be extending, but of course because of key challenges they are not expanding. And if you look at the evidence which you talk about, every innovation that has been scaled up in any country, take it from Ethiopia's health expansion program that increased MCPR over 10 years from 8 to 36. Talk to Malawi's family planning initiative that within the same period took MCPR from 4 to 45%. And even in Nigeria here, when you look at what we were able to achieve with polio eradication in recent years, you realize they have one thing in common, which is finding a channel to link to that community, that grassroots level. Unfortunately, we are not really recognizing that yet, basically because of the fact that we do understand. Everybody you talk to, if I go to people that are implementing HIPs and say, what is the major issue? Say, oh, we have a very weak health system. I say, okay, what is the weakness of the health system? Either directly or indirectly, it will still come back to funding. And I keep on asking, so what is the counterfactual? If we will have good healthcare system or adequately funded healthcare system, what are we looking at in Nigeria? And you hear people say, if we give 15% of the health budget to health, like the Abuja Declaration requires, we will go somewhere. And when I make the calculation, I realize that in 2025, 15% of our budget going to the healthcare system amount to about $18 per person per annum. And we think that we can resolve our problems with that. When you look at the US in 2020, they spend over $12,000 per person per annum. So they're really not comparable. So for me, what I keep on saying, look, we have a health system that is not delivering even for the resources that we spend. Because when you look at the landscape in Africa, sub-Saharan Africa, we are one of the best investors in the healthcare system. I'm sure we are better than Ethiopia. We are better than many other countries in terms of per capita. What is missing is really the fact that we are not getting the value for that money that we are spending, because we can't wait until we have a fully, adequately funded healthcare system before we start scaling this. We need to go into looking at what works.
Thank you.
And I think the healthcare system should identify the reforms that we are having now to identify those channels that will bridge that gap for us. Thank you.
Thank you so much. Thank you so much. Due to time constraint, I think I need to move to the next panelist. So as we scale up, Helen, we know we must measure. We believe here, whatever is not measured is not done at all, because you don't even know where you're starting from and where you're landing, or whether you have reached success or not. So I know FHI has been in it for a long time in terms of the HIP, doing a lot of research in the past, interesting research, and also doing a lot of work to measure the scale-up. How does that impact on the future of the scale-up of the high-impact project in Nigeria? Can you share those lessons with us?
Sure.
Thank you.
So I'll talk a bit about the recent research that we did on the smart...
And you have just about 1.5 minutes.
Yes, I'll try my best.
Thank you.
So I'll talk about what we learned on the recent research that we did on what we call the Smart HIPS project. So like previous speakers have already outlined, the high impact practices are very attractive because they're evidence-based. It's easy to just pick this and insert it into your policy documents and let people run with it because we know this works. What's missing from this beautiful picture is that there are no sort of global measures, no standards to say, if I do IPPFP in Tanzania, for example, and I say I do IPPFP in Nigeria, and I produce results, how are we able to say that we have done the same thing? Because one thing with high impact practices is that there are key components for you to be able to say you've ticked off this, this, and that. And that's what we did within the Smart Hips project, is that we're able to identify key components of at least 4 high impact practices, specifically immediate postpartum family planning, post-abortion family planning, community health workers, that's the CHWs, and PDS, pharmacies and drug shops. And when I say we, as Dr. Nwachukwu already outlined, FHI 360, along with a whole host of HIP sponsors and development partners, worked in various countries to pull together measures that countries are currently using to measure the high impact practices that they are working on. For example, in Nigeria here, what we did going to facilities in Lagos and Kaduna, working with the Ministry of Health, EVIDAF, and Akina Associates, we worked with partners who are really at the state level in the field, implementing. For example, we worked with Integrate E, looking at the measures that they are using to implement pharmacies and drug shop interventions in Kaduna State, for example. We took those indicators that they're using to measure. We collected from a whole host of other partners, SFH, CHAI, and other partners, and we just looked at that across board. And we saw that, yes, there are similarities in these indicators, and even globally from the other countries that we collected from, but then there might be a few things missing. At the end of that whole exercise, what we learned is that everybody seems to be familiar with an aspect of high impact practice as they understand it, but as it is outlined in the high impact practice brief, there are 1 or 2 things missing from the key components of how they are implementing. So what we discovered is that, for example, it's mentioned in the policies, but not in exactly the same way that it is defined globally. So there is a measure of lack of fidelity in the way that high impact practices is implemented. So what we are suggesting is that with the measures that we will be proposing, hopefully by the end of Q1, because we are just wrapping up the work across the various countries that we're working in, we hope that by the time we propose these measures, it will kind of highlight where the gaps are. Because what we're proposing is that we're kind of working backwards. The measures will show us what's missing from our implementation, and hopefully we'll close those gaps. We've heard a lot of great things about what we would like to see at the facilities. For example, we would like to see that when a woman is just being delivered of a baby, she's immediately counseled on family planning. Now, we would like a measure to tell us how many women were counseled on postpartum family planning, and what percentage of those women accepted, or how many of them have intention to, and how can we follow them up? These are the little changes that we'll make in our measures that will kind of help us gain tractions in the hips that we want to.
Thank you so much, Helen. It's quite interesting. Just because this session, we're saying, what are we doing differently, how do we improve maternal health and in family planning space? And I think this is something that we are doing differently, the high impact projects, and then the progress of it, and what has worked in other countries are lessons, and they are truly innovative. So because of lack of time, I plan to ask you to say one sentence in terms of moving forward, but that is not possible. So if I might wrap up from all the speakers, what we have said and agreed is that we should be confident in Nigeria that it will work. It has worked in other countries, and it has worked specifically. We have seen results in Ethiopia and also in Malawi. Can you imagine if we say we have moved our family planning MPR from where we are today, 15%, to let's say 40% in just about 3 years? That would be remarkable. And that was what we saw happened in Ethiopia. And it requires mutual accountability. So that confidence building is something to take away from here. And we've heard also from the Federal Ministry of Health that is leading and coordinating the implementation of the high impact projects in Nigeria, especially in the 2 areas of postpartum family planning and also post-abortion family planning. They've already mainstreamed into the systems. He has told us about the policies that have been these 2 have been mainstreamed into it, the strategic documents that have been developed, SOPs have been developed, and what is most important that we've always identified as a huge gap is implementation at the subnational level. And I'm glad to hear from Dr. Samuel Oyeni that they've signed the compact. So the next is to see how do we realize the realization of the compact that have been signed by the subnational level. He has said a lot, but I think those are the key takeaways from what he has said, told us this morning. And of course, evidence. Evidence is very important, but of course, what has happened in Malawi may not happen in Nigeria. And even in Nigeria, what we implement in Borno, for instance, we cannot go and implement it in Osun State. So we need to tweak it. So you have raised the issue of adaptability, you know, considering the context of where we are, but of course, using the innovations to ensure that we achieve the goals. So thank you so much for that. But Helen has shared with us in terms of the measurement and then the fidelity. So it's not all the same. It's going to impact on the scale up of the future of it. So implementation might differ, but of course, what has come out clearly is the key components of what we are implementing. Nigeria has taken 2 forward. Other countries have taken others. So, and then of course, even the community, we can do it in all other different parts of Nigeria. Is a huge country. So some states might prefer or region do the community pharmaceutical, community health workers aspect of it, or intrapartum family planning. So the room is so large, but what came out of it is identification of the gaps and how do we close those gaps while we scale up the whole process. And but I think this is very innovative, the high impact projects. Whoever came around and initiated it, I'm sure one person sat and initiated the high impact project. And I want to thank those that have done it because it's truly innovative. And I want to thank the team, the HIPTAC team that we've all worked with, and all the sponsors. Thank you so much. And next time we come for our national conference, we should be able to hear different results better.
Thank you very much, Ma. Thank you. A round of applause for them. We'll now take a group photograph of the panel. Group photograph, please. You know, while this panel lasted, it took quite some time. I was asking myself, what can I do? What can I do to stop this panel? Something crossed my mind and said, since Dr. Salma is an appointee of the president, maybe I'll just sing the national anthem and all of them will stand up. And that'll be the end of the session. Are we good? Thank you very much. Thank you very much. Okay, please a round of applause for them as they go back to their seats. Thank you very much, sir. Okay, we'll call on the next panel, and it's my pleasure to quickly invite to the microphone the chair and co-chair for this panel, and we're going to talk about modern CPR shift in Nigeria, a comprehensive approach in achieving universal access to contraception. Let's make welcome Mr. Emmanuel Aja, the Country Director, MSI Nigeria Reproductive Choices, and Dr. Fumilola Olaolorun, I should know. Forgive me, please. That's the co-PIPMA Nigeria. so it's not captured here, unfortunately. Welcome, ma'am. You want to sit there? Maybe here, sir, and ma, so that your panel can stay over there if you come. Just the two of you. Okay, so maybe the two of you there so that we can do more seats. So we need 7 of them. Please, can we get 2 more seats for the panel? There are 7 panelists. So, when you want the mic, just press here.
Good evening, ladies and gentlemen. I know the day is already fast spent, but I'm still very much excited to see the crowd. Everyone still seated and nobody is actually getting agitated and want to leave. So I want to ask that we put our hands together for ourselves. Well done. So we will be talking about NCPR shift, and we have a list of panelists who will help us do justice to this. Starting from Dr. Wakego from the Federal Ministry of Health. Dr. Wakego, can you join us? Dr. Okoye from Bayelsa. Dr. Okoye, please join us. Dr. Habu Dahiru, as the Commissioner for Health, Gombe. Honorable Commissioner, please join us. We have Dr. Muntaka Sadiq Umar, the National Coordinator, SWAP. Muntaka, if you're here, please do join us. And Pharmacist Ugochukwu Alex from the Federal Ministry of Health. Ugochukwu, please, can you join us? Don't mind me, it's a long list, and you know the conversation around MCPR is a very interesting one. And Dr. Omokudu Ido from Society for Family Health, the Managing Director, please join us. We have Alhaji Kabiru Ahassan Shigari. Please, can we put our hands together for Sarakin Sadun? All right, so it looks like we have everyone that we need except the SWAP national coordinator, but we will go ahead and have this conversation. Because of time, I'm not going to be reading out your profiles, and of course, almost all of you are already well known by the people seated here. So there is really nothing to tell them more about you. To get us started with this, I will call on Wakego to make a quick presentation for us. For those of us who were here 3 weeks ago, you would have seen the presentation during the SWAP joint meeting that talked about the MCPR shift. We want to present that and reflect on that, and that will guide our conversation this evening. Dr. Wakego, over to you.
Okay. Okay, so good evening all.
I want to make a brief presentation on modern contraceptive prevalence rates in the country, just like the country rep has said, that this was actually presented at the concluded joint annual review, and this information was gotten from our NDHR. So if you look at comparing the MCPR for 2018 to 2023, you know, in 2018 we had 12%, and then 2023 we have 15%. So this has actually, we just have only 3% increase from 2018 to 2023. And we've noticed also, if you look at the board there, you will see that the people in the urban areas access modern contraceptives more than the people in the rural area. And then looking at the wealth quantile, so you find out that people at the lower socio-economic level have a very low utilization of MCPR than people at a higher economic class. Then looking at the mother's age, so you can see that the very young people, 15 to 19, access MCPR lowest. And then the older age accesses it more than the younger age group. I don't know why. Then the distribution of mother's education, the people with no education are at very low rates, while people with more than secondary school education accesses the modern contraceptive more. Then if you look at the number of children, you can see that people with 3 to 4 children are the ones that accesses the modern contraceptive more than those with lesser children. Next. The next slide. So now, if we look at a deep dive into the state level data, it reveals a significant disparity in the use of modern contraceptives across the zones in the country. So if you look here, you see that Ekiti State, across all borders, Ekiti State has the highest number of usage. That's 43%. And then, although most countries in the south, most states in the southwest utilizes the modern contraceptive, while northwest has the lowest utilization. Then when you come to the northeast, if you look at Gombe has 30%, and then the next state following it is Adamawa, which is just 18%, which is just a deep dive. So I don't know, we'll have to know what Gombe State is doing to ensure that their people are actually assessing the modern contraceptives. So when you look at this at the state's data and at the regional data here, we found out that the southern part of the country accesses modern contraceptives more than the northern part of the country, except for northeast, where Gombe State is taking the lead. And then if you look at Kebbi State, Kebbi, Jigawa, and Sokoto, the utilization is really poor. And that calls for concern, because we really need to, based on what we've been talking about here since, what we need to gain from the last 2 presentations that were made, we saw that we can gain some, especially if a $1 increase in utilization of family planning will lead to $2 increase in maternal and child care. So with this brief presentation, I open the room for further discussion and deliberation on the use of modern contraceptive use in the country. Thank you.
Thank you very much, Dr. Nwakego. What she has presented just tells us that moving MCPR is actually very possible. I remember early this morning, Dr. Fumi had presented to us a scenario that shows that we need at least 2% movement annually. However, if we look at some states like Bayelsa that moves from 3.3% to 16.9%, it tells us a lot. And when you equally look at a state like Gombe that has moved from 16.2% to 30.3%, it tells us that all of this is possible. And that is why we're having this conversation. Before I hand over to Fumi to take this on with the questions, I'm just go to the Honorable Commissioner, Gombe. Please, can you tell this Honorable House what is happening in Gombe so that we can learn from you? Thank you very much.
Thank you. Distinguished participants, Gombe, number one is the political will from the governor. Now, we discovered that we have high maternal mortality and infant mortality. And one of the best ways to reduce the maternal mortality is to use family planning. So when I reached out to him, I told him that the best way we can reduce our maternal and infant mortality is to improve our family planning. He asked me, how? I said, yes. If you invest in family planning, you would see the result in maternal mortality decreasing. Now, we went on advocacy to the State Assembly to get a budget line, to get more funds for family planning, specific. Initially, it was round the clock, maybe under maternal child health, anything, then family planning will pinch something for it. We have no budget line for family planning. As a result of the advocacy to the State House of Assembly, we were able to get a budget line for family planning, and a reasonable sum of money was put in there, and we ensured that we, once we make memos to His Excellency about family planning commodities, he approves and it is released. Now, how did we achieve that? We domesticated the guideline. There was a national policy, there was a national guideline. So we domesticated the national guideline and that we use it as an instrument as a tool to propagate family planning activities in Gombe State. Now again, sensitization became key. So we had a technical working group that is given a responsibility to go into the nook and crannies of Gombe State to sensitize people. And we targeted groups. We targeted those that we feel they need the family planning, and those that could come and have family planning. There are two different set of people. Those that truly need or desperately need, and those that should have. So when we targeted those groups, we sensitized them. And we use also the task force on PHC. Incidentally, we have a state task force on PHC, general, and we use the state task force on PHC, which the membership cut across different backgrounds, the traditional institution, the religious institution, the technocrats in government, and also the technical group and partners. Now, this team went in to advocate for use, and then when we created demand, there was a surge. Everyone now comes for it. So we ensure there's no stock out. And we did a cost-benefit analysis. And with our cost-benefit analysis, we feel instead of procuring from elsewhere, while we partnered, we procured family planning commodities through UNFPA. The first time we procured over 30 million naira worth of family planning consumables. Then we utilized them, and when we came for the 2025 budget defense, we said we are able to utilize it, and this is the impact, and this is the result. We compared the uptake and also emphasized that it has truly helped us reduce maternal mortality. And we saw the data for maternal mortality last year and this year is going down as a result of increased uptake of family planning. So they now beef up the family planning for this 2025. Now, we spent 30 million last time, and this time they said, okay, you can now take 50 to 75 million. So they gave us 50 million for family planning commodities. So this is how it has been going on. And of course, whatever you do, the monitoring and supervision becomes very apt. We have sensitized, and we now go into the facilities and ensure that we strengthen the facilities, training of personnel that are providing service, the service providers. There has to be continuous training in order for them to keep up to the pace that we want in the uptake of the family planning. I think these are some of the things that made us truly get where we are today. Thank you.
Thank you very much, sir, for sharing the Gombe story. That's a very unique recipe, and we'll be talking about what parts of that recipe we can use in other states as well. But first of all, let's hear from Dr. Okoye. What have you done in Bayelsa State? How were you able to move the needle so far?
Okay, my name is Dr. Okoye Ebikapaye. I actually represent the Honorable Commissioner of Bayelsa State, Professor Seifa Brisibe. For Bayelsa, I'm really gladdened the experience my boss, Gombe State Commissioner, shared here. And it's good 2 states are seated here to share this experience and to be learning what went differently. But the first point is the political will. For Bayelsa, in 2020, we adopted and adapted the tax shifting policy. The tax shifting policy enabled us to look at how best within our context we can address the human resource gap. So, different cadre of healthcare workers, especially the community health extension workers, who were available at the primary healthcare centers, were trained to be providers. Initially, you have providers only at tertiary and secondary facilities. So we look at the context of what is our data saying, and then we're able to escalate that to the policy domain where the policy was adopted. And so human resource was trained, and with that, we're able to have providers at every primary healthcare facility across the state. And this had a lot of support from our partners in collaboration with the state government. So there was no facility that a woman who needs family planning would go to, and there won't be a provider. That was addressed. And then secondly, we also had demand generation. So community mobilizers were utilized in creating demand. And as such, women became aware, and then they know that the facilities now provide this service. So it galvanized that need for women to go to the healthcare centers and make use of family planning services that were available. We did not just end with that. For the high impact practices that are mentioned here, this tells you that some context is already adopted around. So we had already practiced some of these high impact practices in terms of ensuring that we change our narrative. By ELSA, you can see the target that we are setting here nationally, that it should be 2% annually. We overtook that 2%. We had more than 2% increase between 2018 to the point of 2023. The period of 5 years, we had a change of about 14% increase from 3.3 to 16.9. These are the practices that we were able to implement. And then we also had resources mobilized, because it's not just the availability of healthcare workers. The financing is a key enabler that will create changes. So community outreaches were conducted, and these were done with funding that was provided by the state in partnership with support with our key implementing partners. So over this period, we had high intensity of outreaches that were identified in hard-to-reach communities where these services were not being provided, and at that point, we now have services being provided to change this narrative. Thank you.
Thank you very much, sir, for sharing the Bayelsa story. Now we'd like to travel to Sokoto. Alhaji Chigari, please tell us what you have done differently in Sokoto. And please tell us in about 3 minutes, sir.
3 minutes? I hope I'll do it in less. Thank you very much. In Sokoto, we started by domesticating the whole process in order to suit our peculiar cultural norms. We are basically a very conservative setup, and for that reason, we have to be extremely innovative, to the extent of trying to change certain words in order to make the whole system acceptable. For example, in Hausa, we call family planning ƙayyade iyali. That is a very negative term for us, for our setting. So we figured that if we tinker with the word, or with the concept, and say, translate it into something which would translate in English into child spacing, that could be a bit acceptable. Well, to start with, I forgot to tell the House that I am the present chairman of Social Mobilization Committee, or Social Behavior Change Committee. So with that, the bulk of our job, we tried to adjust the behavior of our people towards family planning. We collaborate with religious leaders and other partners, stakeholders, like major influencers in the society. We pay advocacies to them, and also, along with them, with their support, we sensitize the public. We pay advocacy visits to different interest groups. Now, the formation of the Social Behavioral Change Committee consists of people from various walks of lives. We have professionals, we have traders, we have religious leaders, we have youth, all shades of sections of the society are represented. And we sit down and examine the peculiar situations that we have and treat each one according to the needs of that particular problem. We do partner with the government, but our level of partnership is not so eloquent, to put it lightly. But we are warming up with the present administration, and I hear that for the first time in the history of my state, family planning is included in this year's budget, 2025, moving forward. So our job is very tough. It is odious, but we try our possible best. We try our possible best to see that we become more innovative and increase our capacity, persuasive capacity, and also our ability to reach out to the target audience. Another thing that we have to contend with is that by the peculiar nature of our people, they need a lot of confidentiality in this. And we understand that, we appreciate that, and we are working towards that. There are a lot of strides that we have achieved that I'm not sure if it is proper for me to mention them here. Because if such news should reverberate back to them, it may, it may put us back. So with what I have said so far, I really appreciate being given the chance to make the explanation that I have done.
Thank you so very much, sir.
Thank you very much.
Thank you for sharing the Sokoto experience. So we'd like to hear from SFH. SFH has been involved in so many SRHR interventions in Nigeria. Dr. Idogo, please tell us what role civil society organizations can play in trying to make this shift to improve MCR by working with the government. We've heard about the importance of political will and resource allocation or resource mobilization. So what role can the civil society organizations play? 2 minutes, sir.
Thank you very much. To start with, civil society, over the years, we work across both the supply, the demand side, particularly looking at how to reach places in terms of scaling supply. We work particularly around community engagements to try and sort of drive demand for family planning. And we do a lot of work around advocacy to try again, of course, around resource mobilization. But I really want to particularly talk about some of the work for us in Society for Family Health we focused on in the last couple of years, which is really how do you expand access by looking at channels and looking at the idea of tax shifting, tax sharing, and pushing the boundaries in a very innovative way. And that's really why over the last 3 to 5 years we focused on looking at community pharmacies and PPMV. These are providers that we like to often say are a bridge between communities and the private sector as you know them. And you have hundreds of thousands of them across the country. We've worked over the last 5 years to generate proof that they can actually offer family planning methods that are a lot broader than what they hitherto were authorized to actually provide. And the good news is that piece of work has seen policy change at the level of governments, now allowing them to actually provide a wider range of methods out there. We've also taken a particular interest. Again, if you look at the data, adolescent was one particular group that were very underserved. And some of the work we're doing is really trying to look at how can you use technology, again, within this group, looking at e-farmer and the idea of sort of digital sort of access to actually grow the uptake of family planning and thereby contribute to pushing the MCPR numbers out. So these are some of the very innovative ways that we've tried to push the boundaries. But of course, there are critical lessons learned. We as civil society, our strength is always the ability to contextualize such interventions. Going to scale, often, of course, will require government. So just talking to what the opportunities out there, going to scale require government actually taking some of this on. I was particularly pleased when my co-panelists talked about using tax shifting, tax sharing to also drop, which these are an additional layers. Of course, there have been challenges around how you channel the free commodities through that channel so that at least you could actually then deal with, again, when my sister, Wakego, was presenting, looking at the wet quintiles and assets so that you're actually speaking to the range of the wet quintile. But in summary, these are some of the innovations in addition to the sort of standard role as civil society we've always played in terms of sort of driving new ideas, new change, pushing innovation to try and contribute to scaling up CPR.
Thank you so very much, sir. And our representative of government is Farm Ugochukwu. So you've heard the success stories, sir, from Bayelsa, from Gombe, and from Sokoto. And you've heard the different recipes that they used in each of these states. How can we make these 3 success stories become the Nigerian success story? What parts of these recipes are replicable, and what can the federal government of Nigeria do? You are the government representative, sir, and we look forward to hearing from you. In 2 minutes, sir.
Okay. Thank you very much. We've been saying that Nigerians, we are good in having policies and guidelines, but the problem is implementation. But when you look at the Gombe, Sokoto, and Bayelsa, you also notice it's because of the implementation of the policy that made them strive so well. Now, the government is going to consolidate on what worked. Based on the fact that we want to increase our CPR, we've been on the 12 since 2018, and now it's 2023. We've shifted by 3 points. It's a remarkable increase, but we need more. And how do we do that? Well, first of all, strategize by increasing domestic funding. Of course, the presentation that Dr. Wakego gave us this evening, it shows that only Gombe State in the Northeast had a good access to family planning. Only Gombe State. And why do they do that? Last year, Gombe procured family planning through our own guidelines. And this year, they've also given out money for the same procurement. That is what resulted with what we just saw now. And then again, look at Bayelsa, what they did through advocacy, and we've been having advocacy plan, advocacy kits, and they're utilizing it. So what do we need to do? Is by consolidating and on what works for us. And it's working, and we're going to consolidate on that. Then, if you increase domestic funding, both federal government and the states, it will reduce the out-of-stock syndrome we are having. And as I'm sitting here talking to you, it pains me so much because I collect the blood from 36 plus 1 state of the federation. Because every now and then my phone will be ringing, we don't have this, we don't have that. But I don't have solution. Why don't I have solution? Because the fund for procurement is very minimal. And the demand is high. So what do we do? Is by increasing the domestic funding, both state and national. What else do we need to do? We also need to move into communities, because she also told us about the community engagement based on the results they have, that those at the urban area receive family planning more than those at the community. So it's giving us information on what to do. And now we are going to move into the community by sensitizing the community leaders and the religious leaders, and also the having chiefs, which have been existing in the country, to strengthen them. Let them move into the community and then sensitize the community. Create awareness that most times when you ask people, do you engage in family planning? You say no. But what is happening is using family planning because probably the husband doesn't want him or doesn't want her to use family planning. And you are asking her question in the front of the husband. She cannot agree with you. So we need to sensitize men to also imbibe in family planning, to also accept family planning, and for them to allow their wife to also use family planning. Those are the things we need to do. And again, we also need to make use of our data management tools, NHLMIs, FPVAN, and warehouse information system. Why do we need to do this? When we don't have quality data, it will dovetail into wrong information at the national. It will not be able to give us a good data that can tell you, okay, this is where you are. But when we start using them by training those that are not using it very well, or rather, the providers themselves, it will help us to go a long way. If you are using 30 number of family planning commodities, it will reflect in your data management that you are using 30. But while you are using 30, and what is in your data management is 10. It doesn't tell us a good report of what we're doing. So we need to strengthen our data management issue. Thank you very much.
Thank you very much, Pharmacist Ugochukwu. And thanks to all our panelists. Unfortunately, I'm not able to give us time to ask any question. But just to summarize, one thing that came out really very clear is that we need political will to move the needles. If we are going to move MCPR, we must all come collectively from government and do the necessary allocation that is required. There are a lot that has been domesticated. Please, let's look at those and see what works. Another thing that equally came out really very clear here is that we need to deal with the problem of stockouts. A lot of demand is being created, and we have had a lot happening to address social norm with advocacies, with demand generation. So what we need to do is to ensure that we address issues that have to do with stockouts. so that when women do go out, they will be able to get services. It pains me that people go to the facilities and they return back without receiving the services that they have gone for. The problem with that is that by the time they come back another day, they are probably coming back with pregnancy. So for all of us, from national, state, and even local government, because we are beginning to allocate resources directly to local government, it has become very clear. If I see that people will buy easily malaria drugs, I wonder why we will not be able to buy family planning drugs. Thank you very much for listening to us.
Thank you so much, Mr. Ima Aja. Please, a round of applause for this panel. Please stand for a group photograph.